Okay, I guess we'll get started. So my name's Penny Corkum, and I'm a psychologist, child psychologist, trained in school psychology and child clinical psychology at OISE, and actually under Rosemary Tannick was my supervisor during my PhD. And so it's a little odd to be standing here and her sitting there, so you'll notice I'll look this way a lot. Anyway, so I'm currently a professor at Dalhousie University in the clinical psychology program, and my area of research is two areas in clinical practice is ADHD and other childhood neurodevelopmental disorders in schools, and kind of the education of children with neurodevelopmental problems. And then my second area of research is on sleep problems in children. And I'm going to stay pretty focused on neurodevelopmental and ADHD kind of research and my clinical work. But if you have questions about sleep afterwards, I'm happy to answer those as well. So I was under the impression I was going to prepare two talks. So I have part A and part B, and probably you probably don't need to hear part A to hear part B, but they should follow after each other. So anyways, but before I start, just a show of hands if you're a teacher, educator of any, okay, parent or a person with ADHD, healthcare provider of, okay, great. So hopefully this will work for everyone. Dr. Tannick gave a wonderful overview of the research and what we know about ADHD. And I'm going to start out just with what I always start out with is 5 key things that I think you should know about ADHD. And I have to say Dr. Tannick covered all of them, but I'm going to review them with you, and I'm going to focus on why they're important in terms of intervention. So my talk is very intervention focused. First of all, every child with ADHD is unique. They can have just inattention, just hyperactivity and impulsivity. They could have combinations of these. So when a child comes to your classroom or you have a child with ADHD, when you know what ADHD is, it doesn't really help you a whole lot because they may have some of the symptoms, but not all of the symptoms. So it can be quite varied. Also, as was mentioned before, there's a high rate of comorbidity. About 80% of children with ADHD have another disorder that is diagnosable. These are some of the most common, so ODD or oppositional defiant disorder, which I dislike and I'll probably talk about later, conduct disorder, learning disabilities, anxiety, depression, sleep disorders, etc. So when a child comes into your classroom or into the world, into your home, really you can only say that you've worked with one child with ADHD. You haven't worked with ADHD children. And again, always put the child first. So it's a child with ADHD, not an ADHD child. So each one's unique, and you need to know that to develop intervention. So if I told you that I was going to move into your area and I had a child with ADHD and that child's going to attend your classroom, what could you know about that child? Really? What would you say? What would be some generalities we could say about, if you don't know anything, you know it's a boy, 8 years old with ADHD. Yes, likely, but not necessarily, right? Because could have the hyperactive impulsive presentation with no inattention, but likely, but not 100% guaranteed. Another generality, yep.
Probably going to have some impulsivity.
Yep, again, likely, but not necessarily, right? Could be some hyperactivity, some impulsivity, but not necessarily. Anything else? Yep. Yeah, so might have restlessness, may not, right? Anything that goes across all children, is there one generality we can make? Some what? Probably has some impairment, yes. So there's some challenge, for sure. Not necessarily. May or may not. So I think the key, this is really the key, is that there is very little that cuts across all children with ADHD. And what that means from an intervention perspective is that you have to take an individualized approach. You have to understand that child and that child's symptoms and challenges and strengths in order to develop a appropriate intervention. Knowing ADHD really, outside of helping you kind of pick medications, knowing that there's going to be some challenge really isn't that helpful. So not to say that you shouldn't diagnose it, but it doesn't help us with intervention planning. The other thing that I think is really critical to understand is that ADHD changes across time. So a child who is 6 in grade 1, who has some impulsivity, some hyperactivity, some inattention, and you make a program for that child at that time, may look different. His symptoms may look different the time he's in grade 4 or 5. So interventions have to be individualized and have to change over time. One intervention doesn't last a lifetime, because this is a lifetime disorder for about 2/3 of the children. Will have symptoms, or maybe a bit more, will have symptoms through their whole life, but it will change. And so what we know is inattention tends to stay as a problem throughout life, but the hyperactivity and the impulsivity tend to drop down. Do they go away? Probably not. They just become more of a feeling inside. So the person with ADHD who was hyperactive as a child may be able to sit still, but they might have that inner feeling of restlessness or impatience. So you may not be able to see it from the outside, but they may still feel it inside, but it's not as noticeable. So ADHD is a lifespan disorder and things change. So you need an individualized program that's going to change over time and be responsive to these changes. Has a significant impact. It doesn't impact all children the same way. So some children, it interferes with their social skills. I know many children with ADHD that actually social is okay. Or some children, it impacts their school performance or academic performance, but again, not all children. So you really have to think about where the impairment is or the impact, and think about that when you're doing your program. So if it's something that impacts them socially, if you're a teacher developing a plan, you may want to work with the parent, develop a plan across all the environments the child's in. It's not really, you really need to kind of take a holistic approach to intervention planning. So we know in terms of social, they have fewer friendships, more turbulent friendships. The friendships don't last as long. In terms of school, they tend to drop out earlier, lower academic performance. Work, they have less, kind of don't achieve as high in the work world or make as much pay because of that. Physically, more likely to be in the emergency room with cuts and bangs and bruises, and to have traffic accidents or motor vehicle accidents, higher rates of concurrent mental health problems like anxiety and depression. And I'd say generally a lot of individuals with ADHD have some self-esteem issues. So think about these things when you're doing your programming. Probably I don't have to preach to all of you here that it's a real disorder, but I am struck that, you know, ADHD is probably the most researched disorder in childhood, yet we're still fighting the same battle, which is it real? And sometimes I have to say on a bad day, I wish I studied Prader-Willi or something that my grandmother didn't know and my mother didn't know, my brother didn't know, because they all think they know more than I do. Because everybody feels like they know what ADHD is, or they don't believe it. It's a really bad situation we're in. I just think there's such clear evidence that it is a neurodevelopmental, genetic, biological disorder, and I wish we could put that behind us to move ahead. Why do I say that this is important for intervention planning? Because I think if you don't believe it truly is a disorder, your interventions are not going to be good. They're going to be blameful, blaming the child, trying to fix the child. You're not going to change some of these behaviors. You can make the environment and the child match, work together better, but you're not going to take a child with inattention and get rid of the inattention. It doesn't work that way. These are hardwired challenges. We can cover it over with some medication for a bit, but inside they're still inattentive, right? So I think it's really important to truly, if you don't believe it's a real disorder, you should read the research, because there's just ample evidence to say that it is. Well, Rosemary wrote a really great review paper a few years ago. I always use that one. Is there an updated version of that one?
It's a bit technical, but it's not bad for reading. There's what the first author is Steve Perrone, and it was published in Nature Reviews Disease Primers. You can Google it and access it. So, and it's got quite a lot of graphics that actually really help deal with some text that I found a bit dense. But it's not bad. It's an update. It's really giving you current knowledge.
Mm-hmm. You just have to talk up a little bit.
I have a definition kind of question. You're all using ADHD, but
Yeah, so the correct terminology according to the DSM-5 is ADHD with an inattentive presentation, a hyperactive impulsive presentation, or a combined presentation. And this changed from the DSM-4. So the DSM-4 were subtypes. And I think I actually really liked the change because there was really no evidence that those subtypes held over time. So typically what you'd see, at least I'd see in my ADHD clinic, the little kids come in and they're hyperactive impulsive subtype because attention hasn't, they're not really in school enough that attention's being tapped out yet. And then they get into school, they become the combined subtype because they can't pay attention, they're hyperactive, restless, and impulsive. As they get older, that hyperactivity and impulsivity goes underground a little bit. It goes away a bit, at least observably, and so then they're inattentive subtypes. So we couldn't find evidence to support these subtypes. So now the DSM says these are presentations with the idea that these can change. So you might have an inattentive presentation, when you're 15, but it might have been a combined presentation when you're 10. So does that answer your question? Yeah, okay. Since we all ate lunch, I always like to do an assimilation, and I do this with my students. I don't know, it's a little bit on the corny side, but we'll do it anyways because it'll get you moving. So I'm going to get you to pretend you have ADHD for a few minutes. And it's a very short presentation. If you have a piece of paper and a pen, you'll need that. And a few things are going to happen. So when you see this little girl looking off, I want you to find someone in the room that has the same color shirt as you. Look around for a moment, be distracted. When this one comes up, the messy desk, I want you to root for something under your desk or in your pocket or wherever you might have it. When this one comes up, shout out something, whatever, answer something. When this guy comes up, I want you to have to move. Now, I'm going to liken this to an itch. Obviously, ADHD is not about an itch, but it is that kind of, when you have an itch, it's hard to not itch, hard to not scratch. And I think the kids feel very much the same. They have to move. So every time you see this, I'm going to tell you a different place to scratch. You ready? And you have to do the task. And so we're going to see who does the best. You're going to get a score at the end of it. Okay. And there's going to be things that happen. There's going to be pictures that are random. I'm going to challenge you to think of something, do a little mind wandering, a little bit of extra thinking. There's going to be some noises that are going to distract, and sometimes there's going to be mistakes because the person who made this is impulsive and might have asked the wrong question. So you have to be careful there. Okay, it's just short. Okay, scratch your knee. It's really itchy. Scratch, 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 scratch. Make sure you're doing the task now. Okay, keep. And focus. What was that? Was that a picture? I didn't see the picture. Oh my goodness. Okay, make sure you're doing the task. Make sure, okay, look, someone have the same color shirt as you. Look around the room. Find someone that's, okay, scratch your back. Scratch your back. It's really, really itchy. You have to do it. There's no way around this. Okay, keep scratching. I don't feel you guys are paying attention very well. Okay, scratch your head. It's really, really itchy. Yeah, very, very itchy. I'm getting hot up here. Okay, scratch your cheek. I really have to move. You really have to move. Maybe the other cheek too. Both of them are sort of itchy. Okay, maybe your back was itchy the last time. Okay, baseball. My goodness, I have to play baseball this weekend. Look for someone with a purple shirt on. And I have to play baseball, and I'm going to be the throw person, and I don't know how to do this. I'm really scared. Look for someone with an orange shirt on now. Okay, scratch your neck. Scratch your neck, come on. Scratch. Oh, TV, video games. I love video games. I actually don't, but they're really good. Where's that coming from? Did you guys see where it came from? I don't know. I think it's over there. You better look over there. Okay, scratch your foot. Lean over and really give it a good scratch. TV. I think I might watch some TV tonight when I get back. I'm not sure. I don't really have a favorite TV show right now. Oh, goodness. I have so much homework to do. When I get back, oh, scratch, 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 whatever is itchy, make sure you scratch it really well. Oh, look for something. I saw that. You have to look. I think you dropped your pen. You better pick it up. And scratch your foot while you're down there, why don't you? Okay. Think of something you'd really like to do. Okay, are you tired yet? Okay, so let's see what score you got. Okay, I'll tell you what they were supposed to be, and you can give yourself a point. So number one is you have to have it, this is the bonus point if you put the date on the top of your paper. Doesn't really count, but if you didn't, you don't get any marks. Your name is number one, your mother's name is number two, your father's name is number three, your brother or sister's name is number four, your best friend's name is five, your pet's name, you might have thought it said teacher, but it didn't. Its pet's name is 6, your favorite activity is 7, your least favorite activity is 8. What you do if you won lots of money is number 9, and the thing you like to do the most is number 10. So how many people got 10 out of 10? First of all, how many people could have answered all those questions if they weren't distracted and restless? All of you, I'm sure. So how many people got 10 out of 10? 9? Whoa, very good. No bonus points. No, that's just, I don't throw it out if you didn't, if you don't write. So 9 out of 10, 8 out of 10. Okay. 7, 6, 5, 4, 3, 2, 1. I got none of them, so you guys are all better than me. So that's hard, right? It's hard to be distracted and inattentive and feeling like you have to move and your mind wandering. And this is a task that's relatively easy. It doesn't take a lot of effort. You can imagine if you had to really pay attention. There's another one that maybe I won't do the whole thing, but I love this website, so I wanted to show you it. So it's called understood.org. And if you have a child or you work with children with ADHD, what you can do is you can pick the challenge they have and their age, and then it has like
I'm in 4th grade, and paying attention is a big struggle for me.
It starts with a child sharing their experience of that challenge and around the child's age, and then it has an activity that they can do, and then it has a expert kind of explaining what the activity means. Do you guys want to see it for a few minutes? Yeah. I really like this.
One side of my body is fighting with the other side. When you're trying to learn about verbs or division, my hands like start shaking. You can feel your body like wanting to get up. I like push my chair back and then just start going everywhere. Some friends are like, "You're weird, Kendall," or "You're really crazy," and so and they're just like joking around. And sometimes they're not. Sometimes I like kick the bottom of my friend's chair and I'm like, "I'm sorry, I didn't mean to do that," and I try to control it.
Some kids have brains that are constantly in overdrive, and that makes it hard to pay attention and stay on task. This next activity will give you a taste of what it's like to have trouble staying focused.
Okay, put away your books. We're going to play a game.
Can you hear it?
In this game, we're going to find homes for the animals. Listen to me carefully. In front of you are some animal cards and a grid. I'm going to tell you where to move each animal card so every animal ends up in the right place on the grid. Are you ready? Everyone take the snake card. Now look at the grid. Put the snake card on the camel in the grid. Got it?
I heard something with snake, but I don't know where it goes.
Good. Now take the bird card and put it on the kangaroo in the grid.
Is anybody
Dylan,
here?
are you with us?
On the kangaroo?
Now take the monkey.
Oh,
Put it on the
I
kangaroo.
don't have a monkey.
Is that yours on the floor?
If you hear one, yell it
Now
out.
find the kangaroo card.
Elias
It belongs on the
he's
ground.
almost friend too, remember?
Emma and Maddie, pay attention. Dylan, are you with us? Okay, now everyone, look at the octopus.
Ew,
For
weird.
your grid. Now look for the elephant. Jacob and Sophia, please stop.
Elephant where?
Put the elephant on the board.
We'll put it in the shower.
Can you see the octopus? I want you to place the rhino on
We
top
saw
of it.
Dino. I saw rhinoceros at the zoo and I
Rhino
bet
on there?
Put the monkey on the floor. Jaden, don't interrupt.
I don't have any
And then put the
animals
shark
left.
on the
Miss
elephant and on the
Aldano,
shark,
my
put the
game is missing a piece.
Ready? Now flip your cards over. What do you see?
We didn't do so well. Anyways, it has these wonderful little,
You probably found that activity pretty frustrating.
Anyways, I don't think we need to watch the rest of this, but it kind of explains why that's hard with the distractions. But there's a whole bunch of, there's ones for reading and spelling and written language and attention, and then all different age ranges. So it's a really nice, little activity to do with kids around demystification and also sharing with parents and teachers. So the fifth thing that I want you to know is that treatment is effective. And when I say effective, what do I mean? What evidence do you use to decide that something's effective?
If you see improvement.
If you see improvement, okay, in the classroom or at home, if you see improvement, you'd say it's effective.
That would be one.
Yeah, that's an individual person's perspective, yeah. To say something's evidence-based, what does that mean? That has research support. And what is research support? So let's talk about that just for a minute, because I think it's really a really important point. So if you kind of think of it like this triangle, so most interventions have some research support. Some have none, but most have some. A lot of it is non-controlled trials, meaning something like a pre-post. I gave it to a teacher. She used it in the classroom. I measured the children beforehand. I measured the children's, say, behavior after the program was done, and I saw improvement. So that would be non-controlled because there's no control there. It may be that the child improved, but what else might have happened? Let's just throw out some ideas.
They had a good night's sleep that night.
Say that louder.
They had a good night's sleep the night before.
Yeah, it might be something totally unrelated. Yeah, or the parents knew it was going to happen, so they, talked their kids into, gave them a reward at the end of the week or something for doing whatever the behavior was. So there's lots of things that could, really be driving those findings. The next level is controlled trials or randomized controlled trials. This is when we randomly assign children to either a treatment group or some sort of control group, a wait list, or let's just say a wait list is a pretty common example. And this we control for all those things that could happen, because if we see that the children in the control group don't change and the children in the treatment group change, then we can say causally that the treatment resulted in this improvement. But a better level of evidence is systematic reviews of all of them, like meta-analysis, where we take a whole bunch of randomized control trials and we look across all of them. Because when you talk about, and I think Rosemary really highlighted this in her talk, every study shows something a little different. So how do we know what is evidence and what isn't? So we really have to look across numerous randomized control trials. And I feel very passionate about this because I think it's my opinion that we waste a lot of money on interventions that have not been proven to be effective. And I guess if I could change one thing in our system, it would be that we use interventions that we know are effective, that have at least controlled studies and maybe multiple controlled studies showing that they're effective. So I also want to share a bit of a case study as we walk through here. So this is a boy I saw a little while ago. He's 8, almost 9 years old. He's in grade 4. And he was referred to his parents due to attention and learning problems. Pretty common. He lives with both of his biological parents. His maternal grandmother lives in the house as well, and his 2 brothers, one younger, one older. No problems with mom's pregnancy or birth information or birth history. And developmentally, he was actually reported to be a happy, easy to care for boy, no sleeping or feeding problems. He walked and talked within the kind of appropriate milestones, and he was fairly independent, had good self-help skills. He's generally healthy. He doesn't have asthma or allergies. His vision's fine. His hearing, debatable. He had a lot of ear infections as a child, as a youngster, and when he has a cold, they seem to get blocked up, and he has some scarring on his eardrum, so something you might want to remember. The parents are both educated. Mom's a teacher, dad's a computer programmer, and there's no real stressors in the family. We talked about trauma earlier, and I think, we have to ask families what stresses the child's under before we make these diagnoses. I'll tell you about another case in a little bit, but clearly if someone's dealing with trauma, you want to be very careful in your diagnosis. In terms of family health and medical or mental health history, problems in the family, immediate family, with learning, anxiety, and ADHD. And the parents feel that both the other children have ADHD. Some questionnaires were conducted. First is what we call a broadband measure. So this taps into lots of different kind of problems that could be going on. And in terms of his adaptive functioning, it was reported to be fine. So he had friends, he was engaged in extracurricular activities. The only area that there was a problem was his academics were a bit low, based on the parent report and teacher report. In terms of clinical problems, inattention was a big problem by parent and teacher report. Then we also gave some what we call narrowband questionnaires, which focus in on a particular area. So these are the Conners, which are ADHD, often used in ADHD assessment. And basically, the parent was reporting a lot of inattentive symptoms and cognitive problems. This is really learning. Sometimes the title doesn't match the item, so you have to be careful there. And the teacher was reporting more diversity in symptoms, so inattention, impulsivity, and restlessness. So unfortunately, in my world where I live and what I see, many children are diagnosed based on just this. A parent coming to the family doctor's office, saying that they think they have ADHD, saying the teacher thinks so, doing a couple questionnaires, bang, they're on medication, end of story. Bad. This should not be happening. I'll tell you why in a few minutes. So let's just assume Charlie, if he went into many walk-in clinics, family doctors, he may have been able to be diagnosed with ADHD and left with a prescription for medication. But I would argue that ADHD is actually quite complex to diagnose. Many of my colleagues who work in other areas think ADHD is easy because it's observable. But ADHD is actually really tricky because the symptoms of ADHD are in every mental health disorder. If you open up the DSM, the Diagnostic and Statistical Manual, what we use to make diagnosis, every one of those disorders has some problem with attention. So how do you know if it's ADHD or something else? So not all that looks like ADHD is ADHD, and you definitely can't judge a book by its cover. And I don't know if Rosemary remembers this story, but a long time ago, my first ever assessment on my own, a private assessment, I worked with a little girl, and she climbed the walls, and I thought, oh my God, this is so easy. I'm going to be so good at this. And I went home, and I was really proud of myself because I knew what she had. And then I called the teacher, and the teacher gave me a whole different story. The most well-behaved, not restless, not fidgety. I'm like, oh, well, there I go. What am I going to do? And it turned out that this little girl was under tremendous pressure during the assessment, not from me, but everybody thought she was gifted, and she felt very stressed by being assessed because her parents really wanted her to get into a gifted program. And so she sort of fell apart during the assessment, which was shown during this hyperactivity, but this girl did not have ADHD. And so we really have to be careful. What sometimes is the observable kind of what's happening out here is not really what's wrong. So how do we go about making an assessment? First of all, we have to assess the core symptoms. And that's pretty straightforward in some way. So does the child have inattention? Does the child have impulsivity, hyperactivity, or restlessness? And what's the severity and impact? So we have to make a diagnosis, we have to have symptoms, and it has to have some kind of impact or impairment. Then we want to look at the onset and the developmental course. And why do we want to do this? It's because it can help us understand maybe it's something else. ADHD doesn't come on when you're 25. You know, if someone came to me and said, I think I have ADHD, and had no history of any difficulties with attention, impulsivity, or restlessness their whole life, then that can't be ADHD. So we want to know what the developmental course is. We want to rule out alternative causes. Let's just kind of brainstorm. Think of things that can look like attention problems. Let's just name some. Put your hand up just so I can see where you're. Lack of sleep, absolutely. Looks like ADHD. Vision problems. What? Hearing, like me, yes. And it's true, though. I do have hearing impairments, and my colleague, who's a dear person, and I felt so horrible, after an assessment we did together, she pulled me aside and she said, Penny, you know, I hate to say this to you, but you look like you're not paying attention. What? And she said, because you keep saying, pardon? Could you say that again? And so now when I do an assessment, I say to the parents, I say, I have some hearing impairment. So if I ask, it's not because I wasn't paying attention. It's really that I didn't hear you. So absolutely, it can look like that. Other, Ainsley? Anxiety, for sure. If you're sitting in a classroom, you're anxious, you can look really inattentive, restless. Boredom, absolutely. It's pretty well endless, isn't it? Go ahead. Hunger, yeah. Some of the really basic things can look like ADHD symptoms. So it's really important to do a good assessment. We want to rule out all these other causes, and then we want to rule back in comorbidities or other disorders that are going along with the ADHD. So many times there's more than one diagnosis. Is that a good thing? Yay. There's more than one diagnosis, and so we want to make sure that we identify those. Why do we want to identify? Why is it important? We could just say ADHD and forget about everything else. Why do we want to know what other things there are?
So that you get the full picture and understanding how to have effective strategies.
Absolutely. It's so important for intervention. And it can make a difference, right? So for example, a child with ADHD and oppositional behavior versus a child with ADHD and a learning disability, you're going to treat very differently. And so it's important to know that. Yeah.
Because if you have a learning disability, it could read as you're not willing to write out your homework or you're not willing to divide.
Absolutely. Yeah, people can misread the motivations for sure. So what should an assessment protocol look like? And I think this is really important for everybody to know so that you can evaluate when a family goes to have their child assessed. I think someone asked this during your talk. What should it look like? Well, in my opinion, standardized testing if the child has some learning problems, because such a high percentage of children with ADHD have learning disabilities or at least learning challenges. I really think it's incumbent on us to know what those are. So I really believe strongly that we should do this. Observations, we want to see this child in different settings. So at school, where would you like to observe the child? If I was a psychologist coming into the school to work with a child for ADHD, what might I want to see? What situations?
Both unstructured and structured time.
Absolutely. Structured, unstructured, could they be quite different? Social engagement, definitely. Say Lola.
Inside and outside environments.
Yes, recess time, yeah, and inside for sure. Yeah, you want to see a nice combination, right, of all of these things. Subjects that they're strong in versus subjects that have more challenges can really sometimes be quite telling. Interviews, I always interview both the parent and the teacher. Sometimes people forget to do one or the other. If it's a problem in the school, they might only focus on the school, or if it's a problem brought to their attention by the parent, that's maybe all they talk to. But it's so important to have both. And informal procedures, reviewing report cards, reviewing past history, those sorts of things. We want to collect data from multiple sources, and this is key because to diagnose ADHD, it has to be pervasive symptoms across environments. It can't just be in one environment. You can't just be inattentive at school. If you're only inattentive at school and you're attentive everywhere else, what do you think it is? It's probably not ADHD, right? It has to be in many situations. So you have to look at home, school, and we often talk to people in the community. So a coach or another person who's working with the child. Multidisciplinary teams, really important given kind of some of, we have different treatments that cut across medical and psychological. So you want to really have all these people on the team and across different settings. So mental health, health, and education. So what's the problem with assessments today? First of all, I think we have way over reliance on questionnaires to diagnose ADHD, and I'll show you the problem with that in a second. People aren't doing differential diagnosis. They're not saying what best explains these symptoms. They're only looking at that first step. Oh, has ADHD symptoms, diagnose ADHD. You have to look a little deeper and say, is there something else? If they have a learning disability, it could be that this child has ADHD plus a learning disability. It could be that they have a learning disability that looks like ADHD in the classroom, or it could be that they have ADHD that looks like a learning, it can be every direction, so you have to do a good assessment. Comorbid disorders are not being assessed. We need to look at those, and this all results in, I believe, overdiagnosis at times, underdiagnosis of many of the comorbid disorders, and often misdiagnosis. So just last Friday, I saw a little boy. He was 8, but he looked about like he was 4. He was very little, had a lot of behavioral challenges, explosive temper, throwing things in the classroom, kicking, crying, screaming when anybody made a request of him. And, definitely lots of ADHD symptoms reported. But when you really dig deep, this is a boy who had developmental problems, who had a very lower intellectual kind of problem-solving ability. He had significant sleep apnea. He wasn't breathing during the night. So is this a child you'd diagnose with ADHD? I don't think right away. I'm not saying never. I'm just saying you want to solve some of these other problems first, right? Because if you're not breathing at night, you're probably not going to be paying too much attention during the day. So the role of the teacher, I think, is really important in assessment. First of all, it's so important not to diagnose or label. Don't say to a parent, I think your child has ADHD, but rather describe the symptoms. He's distracted. When I'm talking, he's looking out the window. If someone walks by the door, he orients there. He shouts out. He has trouble raising his hand and waiting his turn. He jumps in and gains of other kids, and it kind of sets the other kids off. He is up and moving all the time. Describe what you're seeing. Don't label it. So many times, parents come to me and say that the teacher said my child has ADHD. I've even had situations where the principal has told me that the child couldn't come back to school until the child was diagnosed and on medication. And this is just not okay. And I'll tell you, every time that's happened, the child actually didn't have ADHD. And so I think it's really important. Helping parents share what we learned today, hopefully, about what would a good assessment look like, so that when they're going out to get an assessment, they know what they should be looking for, or even directing them in the school to someone that could help them with that. So, consult with a school psychologist that might be able to give them some information about that. Be active in the diagnostic process. I think this is so key. Like, the information I get from teachers is so critical, because teachers are the people who know the normative group. They know what it's like. They know what to expect of children that age range, right? And so there's such an important informant in the assessment process. And so share the information, I think, is really, really important. So I started a clinic in Halifax, outside of Halifax, in a town called Truro, about 15 years ago. And I'm just going to share a little bit about it, mostly because I'm proud, but I truly believe that all children deserve this kind of assessment, and I believe many children don't. So we started this in 2001. It's a partnership with the school board and mental health. We work collaboratively together. I tell my friends who are in business and stuff this, and they look at me like, well, why wouldn't you, right? Like, as if I'm stupid. And but this doesn't happen often, right? These people don't collaborate. We see children ages 6 to 12, and they have to have not been diagnosed with ADHD or learning disability before, never been on medication. What was happening before we started this clinic is people weren't communicating, and the children their needs weren't being met. So it'd take years for a child to be diagnosed and appropriately treated. So they might, the teacher might have concern, bring it up to the parent takes the child to the family doctor, who then takes it back to the school does some assessment, and then it goes back to the family doctor, refers to the pediatrician wants a psych ed, it goes back to the school, then goes back to the pediatrician. 2 years have gone by, no treatment. So that's what was happening in this town. And so we really wanted to do something that would allow for communication and coordination and make the assessment and the treatment kind of happen together. So our clinic looks at screening, assessment, diagnosis of ADHD and any other mental health disorder. So we really do differential diagnosis. We aren't looking just for ADHD. We're looking to see what the challenges are. We have ADHD specific interventions. So we have an ADHD parenting program that all parents can access. We also have what we call a demystification program. So the kids can come and learn about ADHD. I have to say, but hands down is my favorite thing to do. It's a Saturday morning, and they come in wishing they didn't have to be there, and they leave wanting to come back every weekend, because for some of them it's the first time they feel broken. Something's wrong with them. And I'll never forget this little boy. He sat there like this the whole time, stared at me. I thought, boy, he doesn't like me. And at the end, he looked at me and he said, "Are you telling me I'm not stupid?" I said, "No, you're not stupid." And he said, "Can I come back next week?" It was so sweet. So, and it's not that parents or teachers aren't talking about it, but sometimes kids need to hear it repetitively. They need to have opportunity to talk about it. And sometimes being with their peers and being able to talk about it is really helpful. So we do that. we do research and we train other healthcare providers. We just run one Friday a week, and only during the school year, so that's nice for me. Our core team is a psychologist from mental health, which is myself and some others, a school psychologist and a pediatrician. Before the clinic day, we collect lots of information, so questionnaires, observations in the classroom, review the school history of the child, all the previous assessments and treatments. On the clinic day, the child comes, the parents come, psychoeducational assessment to look at learning happens in one room, a diagnostic interview with the parents is happening in the other room. At the end of the day, we kind of wrap everything up and give feedback, which is a treatment plan. And then after that, we implement the treatment plan. So if there's a medication or a medical issue, like the boy on Friday required genetic testing, the physician does that piece. If it's mental health, say needs some counseling or family therapy or parenting program, what have you, then that comes from the mental health psychologist, and the school interventions, the school psychologist takes that back to the school. So we've seen about 400 children, and what's really interesting is only 50% of those children are diagnosed with ADHD. So all of them meet criteria based on a questionnaire, but only 50% are actually diagnosed with ADHD. 42% are diagnosed with something else, so a learning disability or another mental health problem, and 8% received no diagnosis. That's not because there weren't challenges, but there might have been things we want to further explore. You know, go get your adenoids and tonsils out, wait a bit, let's kind of come back and check. These are just some of the kids that kind of jumped out my mind that I've seen in the clinic. And the diagnosis, the first girl, I don't think I'll ever forget her. She had lost her mother, her grandmother, and her aunt all within 1 year. And she was having ADHD symptoms. The school was forcing the father to take her to the doctor and put her on medication. I mean, this girl clearly was having a grief reaction, and there was no history of her having any attention problems. So we listed a whole bunch of things that can cause attention problems like hunger and sleep, but stress can also. So trauma, stress really can look like ADHD as well. Gifted LD, learning disabilities, depression, Asperger's are now called autism spectrum disorder, the higher end. Generalized anxiety disorder, the list goes on and on and on. So there's lots of things that can look like ADHD. So we did a study at the clinic, which I thought was really interesting. We looked at, well, these questionnaires, how good are they? And what we found was that they're pretty good at picking out kids who have ADHD, but not differentiating those kids who have symptoms like ADHD but have something else. So their specificity is very, very poor. And there was another study done in the States that had exactly the same numbers. So it wasn't something that we did. I think this is true, that these questionnaires are screening questionnaires. They can screen, but they're not diagnostic. So back to Charlie. So let's say, thank goodness, Charlie's parents decide to come to the ADHD clinic rather than following through on the medication. They come, we do a diagnostic interview with the parent, and based on that interview, although the questionnaire had high clinical symptoms of inattention, the parent's only reporting 4 out of 9. It takes 6 to meet threshold. So he's subthreshold. He's not clinically elevated. And moreover, these symptoms are only really seen when he is doing schoolwork, homework, those sorts of things, or he's somewhere that's demanding of those processing skills. They really didn't see much hyperactivity, impulsivity, only one symptom, no oppositional behaviors, no conduct disorder behaviors. And he had a little bit of anxiety, but it was very much related to his worries about school. We also did a teacher interview, and remember the teacher had reported lots of ADHD symptoms, both inattentive, hyperactive, and impulsive. And the teacher still reported clinically significant levels of inattention. But the way we ask the questions is we get the teacher to describe these symptoms in different situations. So it's only in academic situations that those symptoms were observable. So when he was out playing in the playground, no problem. He was in gym, no problem. It's only when he was doing academic work. A little bit of hyperactivity, but 2 totally within the normal range. No behavior problems, no mental health problems that teachers saw, but he was achieving below grade level in language arts and math, had weak graphomotor skills. He became frustrated fairly easily with academic work, good socially, good at sports. We look back on his school record, and we find that there was no concerns at all during kind of preschool and elementary, he was reported through all the grades to be engaged, trying, but struggling academically. He had received some resource support in grade 3 and a reading program in the summer between grades 2 and 3. School psychologists went in and observed him in the classroom. The classroom was a very nice classroom, well-structured, predictable routines, and he was functioning quite well. He's getting along with his peers, putting forth good effort. He was a little bit rushing and off task when it was academic, but outside that, he was fine. She conducted a psychoeducational assessment. Again, he was engaged, had a positive mood. He wasn't impulsive or inattentive. He did need some help when he would get off task when it was language-based, but other tasks he was fine on. He had a careful response style, so he wasn't impulsive. And she felt that the testing results were appropriate. So this is, not to bore you with the details, I'll just kind of give the overview, but in terms of his higher order thinking and reasoning skills, he performed in the average range overall, as well on verbal task and visual reasoning. The only thing he had difficulty with was processing speed. So he had a hard time getting things in his eyes, out his hands in a speed it sort of way, which is an important thing in class, right? He also had some visual motor integration problems, not so much the visual piece, but the motor piece. This was really interesting. So in his memory, his visual memory was in the high average range, but look at his verbal memory. In the very, very bottom, he could not remember things you told him at all. He couldn't remember it right away. He couldn't remember it in 30 minutes from when you told him it. What would that look like in the classroom if you couldn't remember what was being said? Yeah, it might look like ADHD. His learning score, which is based on repetition, excuse me, was in the average range, but interestingly, that's comprised of two different subtests. One is visual. He did very well, but he didn't do well when it was verbal information. So even with repetition, he wasn't learning that information. Actually, I'll get you to guess. How do you think he did academically with that kind of profile? What you know about him so far? How do you think his scores would have? Would he be doing really, really super well? No. Where do you think his greatest challenges would be? What's that? In language arts, exactly, yeah. So that's what we see. So math, not bad when it comes to reasoning, numerical operations. He understood math, but he had a hard time being automatic with number facts. Reading comprehension, he sort of got meaning from words, but it was effortful for him. He could read words. He had pretty good sight reading, but when it came to sounding words out, he really struggled. In additional tests of his phonological processing, he had difficulties manipulating sounds and words, both at an oral level and a written level. Spelling challenges, again, when he didn't know how the word looked and he had to sound it out. And writing was really hard for him. Why would writing be so hard with that profile? What do you have to do when you write? What's that? Put just so I can orient. Right, so he's going to have a hard time spelling. What else does he have that's hard for him? The graphomotor, right? It's hard time. How does that B go? How do I print those letters? So when you only have so many cognitive resources, right? And if you're having these struggles, it's really hard to think about things like idea generation and sentence structure and those sorts of things when you still are at the point where it's like, that part is not automatic yet. So writing's often challenging for these children. So differential diagnosis, what do you think we diagnosed him as? ADHD, let's see, show of hands that think this boy has ADHD. You're very good. None, exactly, he does not. Learning disability? Yes, exactly. So what's the definition of a learning disability? There's lots of definitions of a learning disability. Maybe we should put it that way. What's one that's generally accepted?
Below average academic.
Yeah, so average to above average thinking and reasoning skills, but surprisingly underachieving given his thinking and reasoning skills, and some you could see the processing challenges as well, right? So his diagnosis is a learning disability. So we're going to move on now to treatment. Let me just check the time. Oh, I'm good. So we talked about level of evidence. Like I said, ADHD has been researched a lot in terms of intervention as well. Not everything, but what we know through multiple trials is that stimulant medications like methylphenidate, Ritalin, bifenton, all of these ones, is effective. It's effective at reducing the core symptomatology. Not everything, though. It doesn't, I think Rosemary said this today, it doesn't teach skills, right? And so if you have a learning disability, if you have problems processing information, medication is not going to change that. It makes you, I like to think of it as a window of opportunity. You're now at the table and you're ready to learn, but someone has to be teaching you, right? So you can be on medication. If nobody's giving you those skills, you're not going to be learning. So you really have to use both medication and those teaching strategies to move ahead. So stimulant medication has been proven to be very effective. Behavioral management, so using the principles of behaviorism, which we'll talk about in a minute, to kind of, I guess, shape behaviors a bit, and a combination of these two. So those are what is considered strong evidence. We have strong evidence across multiple studies, multiple reviews. We have some evidence for non-stimulant medications like Strattera and for classroom interventions. I'd say that's a growing body of research. All the ones on the right-hand side, they may not have enough evidence, so there might be a study, a non-controlled study or two, or there might actually be evidence against them. But there is not strong evidence for anything listed on this side. That's not to say that someday some of them might not, but today, no. So thinking about interventions to use in an educational setting, I like to think about them in this way. So we have psychoeducation. It's really important that everybody knows what they're dealing with, what ADHD is, what kind of challenges, how to program. So we got to do that teaching part. Behavioral management, remediation, direct instruction, adaptations, and medication. What's the difference between remediation and adaptations?
Remediation is when there's a child, say maybe in grade 7, but their reading level or spelling level as a grade 2, and they have the cognitive ability to learn. It just, because of different situations, they haven't learned. So that would be remediation. And adaptations is when you put something in their learning environment that they can learn at that level, like a scribe or, a reader. Right. They can learn the content, and we're just adapting the curriculum.
Right. Okay. Perfect. So remediation, you're actually trying to fix the problem. You're going in there and you're trying to build the skill. So you could remediate phonological processing by doing programs focused on learning phonology. You could also do adaptations or accommodations, different words are used. You could actually put other things in the classroom that could help that child. So maybe doing pre-reading so that they know those words before they actually have to read for meaning. That would be an example of adaptation. So we can do both of these things, and medication is often used in children with ADHD. So, and I think Rosemary covered a lot of this, but what should we expect? And this is general, I'll get to the research in a minute, but medication tends to improve those core ADHD symptoms, inattention, impulsivity, and hyperactivity. We do tend to see some improvements in some cognition, so things like working memory, executive function, motivation. And we see some changes in academics, though not in achievement. So you might see more on-task behavior, more task completion, iffy evidence for accuracy, but you don't see changes in actual achievement. So they're not achieving better, they're just doing more. And so that's why you need those psychosocial interventions. Medication's not enough, because it's not good enough just to do more. You actually have to do better, right? You have to learn. So there's little impact on academic achievement. When you find it, it's very small effects. There doesn't seem to be any carryover effects. So once the medication's no longer taken, these improvements go away, probably because we didn't put the right other things in place. And Dr. Tanek talked about the questionable long-term effects. So first 12 months, there's pretty good evidence. After that, for medication, iffy. Yeah, please.
I have some families that I work with that allow their children to have breakthrough medication, and they, I don't know, say for the weekends, the children don't take it. I don't know, is the medication work, I'm not too familiar with it, instantly, like,
Yeah.
or does it carry through the system?
Yeah. So first, I'll preface my response that I'm a psychologist, not a physician, but I do know quite a bit about medications because I work with physicians that are using these. But so you can see here, though these medications can have anything from a 4-hour half-life up through over 24 hours. So it really depends on the medication, whether you can start and stop it. And it depends on the child. Some children metabolize it quickly and it's not a problem. Some kids, you can take them off for a weekend or Christmas and it's fine. Other kids are going to have to go through that whole adjustment again and have side effects to build back up. So it's really hard to answer that question. It's very individual.
I just went through this and the doctor told us that the stimulant medications listed, I think we talked about this exact chart, but just black and white. They go in and they come out at the end of the day.
They do, yeah.
So they have that 10-hour span, approximately, on average, that they work, and then after that, they're out in the system. But some of them have to build up,
Yeah.
and those are the ones that would work as well with medication.
Yeah. So the first two groups are psychostimulants, they're called. They're all they say in and out. They have short half-lives. They don't last long in our bodies. And then the non-stimulants have to build up. They're more like an antidepressant. They're not necessarily that, but like an antidepressant, you don't get an effect right away, right? It takes some time. And so it really does depend on the medication. I think the concern, and quite honestly, I agree with the concern, is that we went from using medication twice a day during school time. During the weekdays, I remember when I started working at Sick Kids, and that's what we did, right? And over a 20-year period now, we have medications that are all day long, every day, no holiday. So children are taking, I don't remember the exact number, but 3 times as much medication as they would have 20 or 30 or 20 years ago, right? Just by the types of medications we're using, not the type, but the way we're using medication. So, and my research looks at sleep. So these medications impact sleep, and sleep impacts attention. So we get in these vicious cycles. So that's not to say that medication isn't helpful and effective, but we do have to be really careful that it's not affecting sleep, that it's not affecting, in a bad way, appetite or growth or what have you. So it's a bit, no medication comes without some side effects. And so you do have to manage those. So let's just look at each of those areas broken down a little bit. I just want to look and see how much time I have. Okay. So knowledge. I think knowledge is really key. We have to know about ADHD. We have to know about intervention with ADHD. Teachers need to know, educators, parents, and the students. I think this should be our first thing we do when someone's diagnosed. We should make sure that everybody on that team that's going to work with that child understands what ADHD is and how to help the child. One of the programs we do, which is really fun, is we do a demystification for teenagers. And I was doing this at a school board, and the principal called me up and said, "What are you doing?" So why? So they're all coming and saying, "I need this. I need you to slow down in the class." And so they were advocating for themselves, which is really cool. And so I think they need to know their strengths and challenges in order to do that. Behavior management, so this is using behavioral principles, so those ABCs, the antecedent behavior consequences. I don't know, Rosemary, what you think. I think we're seeing that as outdated somewhat, and we're moving away from it, but there's some really, these are powerful interventions. They don't have to be negative. They can be positive if we use them right, but I think the trend is to move away from that, and I'm not convinced that's good. I think the trend towards making them positive is good. We shouldn't be humiliating children. We shouldn't be making them stand out. We shouldn't be giving punishment. But we can do things with these principles that can really help children in the classroom at home. School-home communication, that's probably one strategy that seems to be really effective if done well. My son has some challenges, and I went through a year where I got a call every day of my life complaining about my child, who really didn't have any behavior problems but had some other learning challenges, and it drove me insane. Like, that's just not effective, right? It has to be positive. And I remember sitting at this meeting with all these teachers. He's in junior high, and I let it happen because I just wanted to see what happened. Each one took a shot at him. Every one of them. I let them all go through, and then I said, let's just stop. Let's just think of what you just did. That's my child. Each one of you said something negative. Not one of you said something positive about my child. Like, you can't do that, right? Like, these are parents who love their children, who want the best for their children. We have to consider that child a child first, in the family, and really be kind about that. So we have to be positive. So homeschool communication is great, but it has to be constructive. It has to be positive. And we have to protect the child's self-esteem. Nothing bothers me worse than humiliating children in a behavior program by having it on the board, and everybody knows that Johnny never gets it. He never gets to go Friday fun day. I hate that. I think that's just wrong. And so, unfortunately, behavioral strategies people are turning against because of those kinds of things that we see. But that doesn't necessarily, we're throwing out the baby with the bathwater, I think, because I think there's some good things there. Remediation, so there's no real direct instruction. You can't, people have looked at, can we train attention? I would say the results, are not great, right? That'd be like training my eyes to be brown instead of blue. It's probably not really going to help a whole lot. But we can remediate all those other things that Dr. Tannock talked about. So the social skills, the note-taking, the homework doing, the time management, we can remediate some of those skills. Adaptation's really critical. So how can we set up this environment to be the most conducive for this child? So I kind of think about them in these categories. So let's just kind of brainstorm. Physical setting. What can we do in the classroom to make it more conducive to, say, your typical child with ADHD, let's say, who has a combined presentation, has some impulsivity, some restlessness, and some inattention? Just talk a little louder, sorry. Yeah, think about where we put them, right? Like, you don't want them in a distracting place, but you also don't want to put them way over there by themselves. That's not good either. So thinking about kind of where they're in the classroom, where you are as a teacher relative to them.
Who they're sitting with?
Yeah, who they're sitting with, for sure. Who's going to interact well with them, who's going to support them. Sometimes I find that teachers will put them with like the best students, but those students, best academic students, but they may not be tolerant of the behavior. So you want someone who can really interact with the child nicely and set good behavior standards, yeah.
In classes, I see they have a lot of sensory tools.
Using sensory, thinking of ways to get those little breaks in there that they can get out some of that energy in a productive way. Yeah, great ideas. Other?
And have structure to the classroom and prepare for transition, like they got to go from, say, the fifth to the busy room. And colors, like now, teachers love to put colors all over the wall. But you got to be careful if you have an attention deficit child because they're just bobbing around.
Yeah. So there's kind of the right sensory, right? We can't overdo it. I've been in classrooms where there's stuff even on the ceilings. You couldn't find a place not to pay attention, On the other hand, no stimulation isn't good either. But I really love your rules, structured, predictable routines that are flexible because of the school system. They have to be, right? So it doesn't have to be rigid, but it does have to have some sort of predictability to it so the child can kind of plan on it. Any other key we didn't talk about instructional strategies. How could you change how you're teaching to better maybe meet the needs of a child with ADHD? Let's just say pure ADHD. That's what we're worried.
Visuals or gestures to your education?
Yeah, so more multisensory, maybe using different ways of teaching. Children with ADHD like novelty. So increasing the novelty, but also some familiarity as well. You want a combination of these.
Teach in chunks, not
Absolutely.
big long
Yeah, chunk it into pieces that are digestible, manageable. That's really a great strategy. What about evaluation strategies? How can we change those?
Again, break it up and really try and look for opportunities for that the child succeeds as opposed to when they're screwing up.
Yes.
They really need that little bit of...
They need that positive for sure, yeah. And, you know, I think that's one of the hardest things is that many of these kids just do not get the positives, right? There's so many things at schools and in life in general where the kids who do well get reinforced for, you know, the student of the day, the student of the week, and these kids just never get that, and it's really sad. So, evidence for treatments in the classroom. I was really interested in this. So this was, again, like a systematic review, and across many studies, 43 studies, which was over 2,000 participants. And although these were statistically significant, I guess I was a little less than overwhelmed with the effectiveness. So the amount of schoolwork completed was increased by 15%. It didn't seem to me like huge. Improved time on task was 12%. Maybe improved accuracy when it comes to arithmetic, but that was really it. And the lower the dose, the less effect. So medication's helpful, but it's not the end-all and be-all by any stretch. In terms of classroom modifications, so non-medication types of interventions at school, this was a review article, systematic review of 89 studies. And that behavioral stuff, looking at the ABCs, was really, that's where the evidence is. And so while these are being kind of put aside, they really have been shown to be the effective intervention. Self-regulation programs, helping the kids self-regulate. There's a growing body of research for that. And in the general classroom setting actually was where the biggest effects were. So I was really interested in that. Keeping them with their peers in that classroom setting seemed to be where the biggest bang for the buck was. And it also improved their classmates' behavior. So this is what I always try to say, that you might work on, you know, as a teacher, you have to learn these new skills for child A, but those skills you can generalize to all the children. And so it's, worthwhile. So in terms of Charlie, he had a learning disability. Let's pretend that Charlie had a learning disability and ADHD, just because that's what we're here for today. So what might we do for Charlie? Let's just throw out ideas. I have 10 minutes. Yes.
Sure is mine.
What could we do for Charlie?
You can have a list at home of all the things he needs to do to get ready to come to school.
Yeah, so some organizational strategies. Yeah, time management strategies for sure.
Little notes in the bathroom. This is what you need to do. Brush your teeth, brush your hair.
Yeah.
Whatever.
Yeah, and those things can make a huge difference. I remember for my son, I just had on the way out the door was this is what should be in your bag. And he could never get everything in the bag. Once he had that reminder, it was a non-issue, right? So we can kind of eliminate some of those stressors. Medication, you know, Charlie, it's hard to say because Charlie didn't really have ADHD, but for many children, I think about 85% or more medication is used, but maybe not always in the long term. But again, really think of it as a window of opportunity. Get in there and do the other interventions while the opportunity is there. I'm going to skip this just for time because I want to talk about this. So as you can see, I kind of have a passion about behavioral stuff. I worked as a behavioral consultant for a number of years between my master's and my PhD, so I believe in it. So within a certain limitation. So behaviorism is a theory of learning that's based on the idea that behaviors are acquired through conditioning, or what reinforces behaviors will make you learn. That has to be a behavior that's not intrinsic. So I don't believe that we can change things like attention or hyperactivity. I think we can kind of manage it, but I don't think it's a learned behavior. I think it's generated from within. But things like avoidance, acting out, frustration, these kinds of things, I think we can actually use behavioral strategies. And there's a lot of different and slightly different approaches. So you probably have heard of like applied behavioral analysis, which really looks at the A, B, and C. Functional assessment, which is my favorite, because I really think when I see a behavior that's problematic, what I think about is why? What's the function of this behavior? So I said earlier that I was going to complain about oppositional defiant disorder. I think oppositional defiant disorder, first of all, there's very little evidence for the stability of that disorder, but these kids are having behavioral challenges. I've never met a child who met criteria with ODD that I couldn't find a reason why the child was having a behavioral problem. The boy on Friday last week that I worked with, he wasn't a bad kid. He wasn't a broken kid. He had significant behavior problems, but he had a lot of challenges, and he was frustrated in school. And so we need to look at what's causing these and work on that instead of labeling this kind of, I think it scapegoats the children. It's like, oh, well, he has a behavior problem. There's nothing I can do for him. And then positive behavioral supports look more at the antecedent level. So we can change the antecedent. We can change so that antecedent is what triggers the behavior. We can change the behavior by kind of developing better behaviors or new behaviors, and we can change the consequence. What's reinforcing? What's making that behavior stay? We can also think about the function. So I'm going to walk through this just in the last few minutes. So these are some key points when you think about behavioral management. The child's behavior is not willful. They're not trying to do it to piss you off, although some days it may feel like it, but they truly are not doing that. I did an interview with a teacher last week, and I have to say, I interview teachers all the time, and I love all of them. Generally are fantastic, but this one teacher was blaming the child and really thinking that he was like manipulating and being bad just to like give her a hard day. And it was really hard to tolerate that. So I think we need to move away from that. And there's usually a reason for behavior. So those are kind of the big pieces. And we want to think about all of these things. So the setting. So what are those distal events that set the stage for some of the challenges? So let's go back to Charlie. What would some distal events be? Not in the moment. So let's say Charlie has difficulty when he's doing academic work, which is true. He goes off task, he wanders, he doesn't complete his work. So that's the behavioral challenge. What are some of the things that are not directly related to that, but probably set the stage for it that we talked about during the assessment? Yeah, his learning disability for sure. So he has processing problems, graphomotor problems, he has some anxiety, he might have some hearing problems. So we want to know those things, and we want to plan for them by doing things like where are we going to sit him? Can we use some assistive technology to help get around some of those graphomotor problems? So we want to think about the setting. The antecedent is in the moment. What is that that's causing the behavior problem? So for him, it was the work's too challenging. He didn't know how to do it. So he'd get up and sharpen his pencil, go to the washroom, hang out with his friends, and all that. And then what was the consequence for that? Well, his teacher just kept redirecting him. Go back to work, Charlie. Go back to work, Charlie. But then it's recess time. Charlie never had to do his work because, he'd go back, do 2 minutes, and then he'd go to the washroom again. So what's reinforcing that is the function. What do you think the function of his behavior is? It's avoidance, right? To escape, to avoid, to avoid it. Actually, it's probably easier I'm going to skip that one. So we talked about the setting events, we talked about the antecedent, the behavior problem, and what's kind of maintaining that behavior problem. Ultimately, we want Charlie to sit and finish his work. But when we get to that point, what's going to keep Charlie doing that? Do you think Charlie, when he's 8 years old, is going to be intrinsically motivated and happy that he did that? Maybe, but maybe not. You might need to use some other reinforcement. Maybe when Charlie finishes something, maybe Charlie could get access to something he really enjoys, a high-level, high-interest activity, time on the computer, let's say. But in the interim, as you're working towards the desired behavior, we can do a replacement behavior. What could be a good replacement behavior? So think of the function. The function is to escape because he doesn't understand. So what could we use as a replacement behavior? Yeah, help seeking. Yeah, so that Charlie recognizes. First of all, in the antecedent setting events, we're going to reduce down the demand. We're going to make it more at his level. But then, if he does have problems, we want him to seek help somehow. So we can come up with lots of ideas. Maybe there's a little thing on his desk that's, green, red, and yellow, and red's up when maybe it's on all the kids' desks, so the teacher knows when they need help, or maybe he has a peer support person that can help him, but that's exactly, and then we can reinforce that behavior while working towards the desired behavior. When we do this, what we want to make the behavior is irrelevant, inefficient, and ineffective. So irrelevant because he doesn't have to do it anymore. He doesn't have to go to the bathroom to avoid what he was avoiding. Inefficient, it's easier to turn over the little thing saying I need help than to go somewhere else. Ineffective, he goes somewhere else, he's still got to finish his task, so it's not really working for him anymore. So we got to think of those three things in order to change behavior. We talked about those. And I have 2 minutes left, 3 minutes, so I can ask a couple questions. I just want to, I'm making a plug, I'm being selfish, I'm sorry, but I am trying to recruit school boards across Canada for a program that we've developed called Teacher Help. We're doing research on it. Basically, it is teaching, there's 3 modules for ADHD, learning disabilities, and autism spectrum disorder. So it's for classroom teachers to learn how to work with, to develop programs for children with those problems in their classroom. And if you have a school that might be interested, feel free to give them my email, or and you can find out more about it on the website, but you just type in teacherhelp.ca. And I always like to finish with a couple things. One is I did focus groups of kids with ADHD across the province in Nova Scotia. It was a very powerful experience for me to hear their voice. And what came, over and over again, that they felt that people thought they were stupid, lazy, crazy, and bad. And I think we don't want our kids feeling this way. And what they wanted me to tell everybody when I go around and talk is that they're not much different than others. Teach me the way I learn. Don't expect us to make mistakes. They felt like everybody's waiting for them to make a mistake. Don't wait for us to mess up, and treat me the way you would treat others and treat yourself. So I'd like to end with that. And also my favorite quote by Ross Greene, and I truly believe that, is children do well if they can. If they can't, then we have to figure out how to help them. And I think with that, I will stop and I can answer a couple questions, and then we can wrap up.
A lot of the things that I read about ADHD, learning system, or based on, younger kids in the classroom. And I have a couple of kids in my caseload who won't even go to class at this point. They're 15 years old.
Yeah.
And they're just socially promoted, and work is difficult. They walk in, they walk out, they wander the halls where they need to.
Yeah.
And what can a person do? The other thing, we could work with them in an LA room back before inclusive.
Yeah.
But these kids aren't including themselves
Mm-hmm.
in the school structure.
Mm-hmm.
Keeps my avoiding it, and I am at a loss as to how to help this.
Yeah. In case people didn't hear, the challenge is children who are older, who have ADHD, whose needs may not have been met in the school system up to that point, and now they're sort of buying out of the school system, so they're not engaging, they're not going to class and that sort of thing. It's challenging, because then I don't think you're dealing with the ADHD behavior so much. You're dealing with all the secondary, they may have some depression or some anxiety about this. So, I think that you kind of have to have a different intervention. But I think what to me it speaks to is why it's so important early on to intervene, because it gets more and more challenging, right? And especially in high school. One last question? Yeah.
You were talking about the clinic in Nova Scotia. So how do your families and say paying for their assessment and dealing with some of the counseling services, how is that funded?
Yeah, so we are just fortunate, to be honest. So at the time that we started it, there was a big move on partnerships, and so it's all publicly funded, which is wonderful. So the families can self-refer, or teachers can refer, or physicians can refer, whoever. Obviously, the family has to agree. And the school board pays their piece, we pay, mental health pays our piece, and the medical people pay theirs, so we all just cost share resources. So it's wonderful, and I truly think, I just wish all kids could have this, right? Because maybe not everybody, maybe we can take some guesses, but I just think that they deserve to really have a comprehensive assessment where we know what's going on and have the right treatments. And I think so many kids don't have that opportunity. And I have to say, I mean, in our kind of, you know, these days when resources are so slim, I always feel like we're a little on the cutting block, right? Because we're seen as like a CADDAC service because, you know, someone actually is doing an assessment. Systems moving away from assessments. So our mental health system just generally is come in and there's a few questions and then bang, you're into treatment. And we don't even know what the friggin' problem is. And how do you treat someone without knowing what the challenge is? Anyways, some thoughts. I think I'll end now. I'm happy to stay around during break, and perhaps I'll see some of you back for the second session. Thank you very much.